everyone, and a very warm welcome to everyone joining us today. It's a pleasure to have all here for yet another inspiring session hosted by Dream USMLE, where we continue to our mission to guide, empower, and connect international medical graduates on their journey towards the success in the United States. So today's webinar is about two journal, I would say, so which were presented by two renowned, I would say renowned member of the Dream Assembly, and they will highlight different aspect of the journals. And we're honored to have us with our distinguished speakers and mentor who have walked this path themselves and are here to share their experiences. Okay, so before we begin, I would like to take a moment to thank Dr. Abdullah Masood, the founder and chairman of Dream Assembly, for his continued leadership and for creating this incredible platform that connects aspiring physicians across the globe. So Dream Assembly was founded in 2015 by Dr. Abdullah Masood, and it is a non-profit initiative committed to empowering international medical graduates, particularly those from Bangladesh, in their pursuit of medical careers in the United States and beyond. So, over the years, Dream USMLE has built a strong community of mentors, aspiring physicians, offering structured guidance, peer support, and educational resource to help IMGs navigate their every stage of their journey. So there are several key initiatives like several young physician workshops conducted both in the US and Bangladesh, targeted webinars focusing on residency applications, professional developments, and career readiness. Comprehensive preparation programs from USMLE Step 1, Step 2 CK, Step 3, OET, and residency interviews. Support for the US clinical experience and opportunities in research and publication. Also, mental health support and mentorship networks to promote well being and resilience. And finally, career counseling webinars covering pathways in the US, UK, Canada, Australia. So, beyond academic, Dream Assembly is also engaged in philanthropic activities such as organizing medical aid for Bangladesh and actively shares educational contents, success stories, and community updates through its social media platforms, including Facebook's. So, at first, I just want to introduce myself. I'm Dr. Marajul Islam Oni. I graduated from Shohid Tajuddin Ahmed Medical College in 2020, and after that, I started preparing for step one. I completed my step one, and I completed my step two CK. And after currently, I'm applying for residency. And as I can see, I have been member from the Dream Student since 2022, and it was a great journey for me. And I've been member of the several division of the Dream Assembly, like Division of Advancement, Career Development Division, and Journal Club. So, without further delay, let's get started. So, I would like to introduce several of the members. So, at first, I want to introduce Dr. Jubair Al Alam, who is a lecturer of the Green Life Medical College. So, please introduce yourself, Dr. Jubair.
Hello everyone. I'm Dr. Zubair Al Alam, currently a lecturer working as a lecturer in Green Life Medical College, Dhaka, Bangladesh. And I was graduated from Sir Solimullah Medical College, and my year of graduation was 2023. And I am currently a student from the Dream USMLE Step 1 18th batch. I am still students. We have some classes as well. So this is my first journal club presentation as well, my very first journal club presentation, and I have been preparing myself over the first few days, and I hope you guys can enjoy it, and hope we can all learn something together. Thank you.
Mm. Thank you, Dr. Jubair, for giving us a nice introduction. And now I want to give floor to introduce Dr. Mohammad Zakir Hussain, who is a graduate from the Dinajpur Medical College. Please introduce yourself, Dr. Zakir.
Hello everyone, I'm Dr. Zakir Hussain, graduated from Dinajpur Medical College. Session was 2017-18, and now I am preparing myself for USMLE Step 1, and I am a member of Dream USMLE Career Club and Journal Presentation Club. So thank you everyone for joining with us. I tried to present a article that is related to this season and to our family members, especially old age members, in this winter. So that can be helpful for you everyone, and I think you can enjoy it.
Mm. Okay, thank you, Dr. Zakir, for the nice introduction. And now we will start the main session. So, Dr. Zubair Al Alum, who will present us about a title. Let me give you the title: Marine Predator Strikes Rectally Inserted Eel Fish Causing Colonic Perforation, a Rare Case Report and Review of Literature. So, please have the floor, Dr. Zubair.
So thank you very much, Dr. Mirajul Islam Oni, sir, for giving me the floor. So today I'm going to welcome you all to the Janaka presentation. And today I'm going to present an interesting case report, which is very much important and memorable to me personally, and also with integrated literature review as well. So, the title of my case report is, as you can see, the marine predator strikes rectally inserted eelfish causing colonic perforation. Rare case, extremely rare case report and review of literature. And as a presenter, I myself, Dr. Jubair Al Alam, is presenting to you this case. So here you can see the front page of that article, which was published in Annals of Medicine and Surgery, and this is the front page. I am not the author or co-author of this case report, but I was strongly affiliated with this case, particularly as an intern doctor in the Department of Surgery, Sir Soliumullah Medical College. So I had observed this case from the beginning to the end of this particular case. So I will walk through you this presentation after this. Thank you. So, the first of all, why these case matter, why I chose this case report particularly, because it is exceptionally rare mechanism of trauma leading to rectosigmoid perforation, and only 3 cases report worldwide. And delayed presentation and diagnosis associated with severe sepsis, which can lead to poor prognosis. We will see in the case report. Surgical options like a Hartmann-like procedure, which is preferred and physiologically sound choice in this particular case report. And lastly, challenges that arises from unreliable history, social stigma, and atypical radiological findings, which we will find in this particular case report. So the background behind this case report is that gastrointestinal perforation is a very common surgical emergency with high morbidity and mortality for about 30 to 50%. And foreign body related perforations are very rare, less than 1% of abdominal trauma caused by these foreign body related perforations, and most colorectal, specifically colorectal perforations, are iatrogenic. For example, we know colonoscopy and sigmoidoscopy, and followed by appendicitis, cancer, diverticulitis, or rectal foreign bodies. Now, rectal foreign bodies arises from various reasons, for example, sexual activity, psychiatric illness, violence, medical procedures, or accidental sources. And the main thing is that the patients often conceal the history in such cases, which proven to be quite complex and obstacle for the attending physician to diagnose and ultimately in the course of treatment as well. And perforations bilaterally introduced eel fish is extremely rare. As I've said earlier, only 3 cases worldwide is reported globally. And so let's start by with the patient presentation. So 25-year-old male came to us in Sir Solomon Medical College emergency department, who was conscious at that time, and after even initial evaluation the patient was shifted to surgery department. At that time we were the attending physician. So the patient was unconscious, so the history was provided by the patient party, the patient's relative. So they said that the patient had 4-day history of abdominal pain, followed by 1-day history of loss of consciousness, and the patient came to us with high grade fever on arrival. And as we said earlier, the patient was unconscious, and the patient's party, the patient's relative wasn't very cooperative, or they didn't know any details about the patient's previous incidents or such. So entirely, the patient's history was quite unreliable to us. There was no clue or anything to guide us through in the next. So after the course, there was the physical examination by the attending physician. As you can see, the first GCS Glasgow Coma Score scale, 8, quite low, 8 out of 15, where you can see E2, M3, V3, and the vital was recorded. As we have said earlier, high grade fever. So there is 103 degree Fahrenheit, a very high level of high grade fever, and the pulse was also bit raised, 125 beats per minute, which was weak and rapid and steady pulse. BP was low, 70 over 50 millimeter mercury. So from this vitals scenario, you can see the patient was already going through the stages of shock, and the room saturation was 92% in room air. Now on systemic examination, we particularly focused on the abdomen. The abdomen was tense, tender, and there was a strong muscle rigidity and guarding. And quite important finding is the liver dullness on the right side was obliterated, which was a important clue for us to think through the perforated case. And after that, DRE, we also performed DRE and proctoscopy, which from which the findings were came out normal. So up to this point, a differential diagnosis was, of course, perforation of gas-containing hollow viscous, and also it can be generalized peritonitis with severe septic shock, and also we considered the options like severe appendicitis or burst appendix. So after that, we go through some investigations. So our first main choice of the investigation was X-ray whole abdomen in anterior posterior view. It was supposed to be in erect posture to visualize the free gas air underneath the dome of the diaphragm. But as I have said, the patient was unconscious. We couldn't perform it in erect posture. But whatever it is, the X-ray whole abdomen in anterior posterior view shows that free air under the right diaphragm, and there was some atypical bizarre radial opaque shadow in right iliac fossa, which I will show in the later slide. And all other pre-operative laboratory investigations, blood work, urine analysis were consistent with features of severe septic shock. And another thing was CT scan is a guideline, is another choice of investigation in these particular cases. But as we have said earlier, due to the severe instability and urgency of the nature of the patient's case, we couldn't perform the CT scan because we have to we move towards the surgical intervention as early as possible. So this is the X-ray of whole abdomen. The night the patient came to us, we did the X-ray. So here you can see in this slide, right underneath the right dome of the diaphragm and above the superior border of the liver, you can see a linear black shadow of free air gas. So that gives us the clue of about the perforation. You can also see in this stomach region there is a metallic bulb. So it says that the patient was already nasogastric the patient already had inserted the nasogastric tube, and this is the bizarre thing that these radioapic atypical radioapic shadow that showed in the right lumbar or right iliac fossa region. At that time I still can remember at that time there were about 5 to 6 attending physician in our department, and we were bit puzzled and quite puzzled what this atypical bizarre radioapic shadow means, but we couldn't find any conclusion. So we hope for the best for the surgical intervention. So, as a natural course, next comes the surgical management. After preparing the patients as quite fit as we can for the surgery intervention, we did the emergency exploratory laparotomy. So, abdomen was open. The first thing that we see peritoneal cavity filled with fecal matter and pus. It was really a tough situation in that case. And surprisingly, in the next course of event, 25 centimeter putrefied eelfish found intraperitoneally. Again, reminding you this, the attending physician didn't had any clue about this rectally inserted fish. So it was quite a surprising and surprising thing to see a 25 centimeter long putrefied eelfish that was found in intraperitoneal in the abdominal cavity. Multiple fish bone clustered in a intraperitoneal cavity in the abdominal cavity in a particular area, and there comes a large perforation site at rectosigmoid junction. So after finding the perforating site, the attending surgeon decided to go for the Hartmann-like procedure. We will shortly discuss about in the later slides. And after done the procedure, thorough peritoneal, vigorous peritoneal wash and toileting was done. Pelvic drain was placed and abdominus was closed, and without any further delay the patient was shifted to ICU, as the patient already came to us in a severe septic shock. So we didn't delay the matter. We immediately shifted the patient to ICU for better management. These are the glimpses of the surgery that were taken in that day. So you can see this long petrified fish is the that petrified eel fish. As you can see, this is the surgical trolley. All the instruments are laid out. So this is the length. Apparently, it is more than half of the length of the surgical trolley. So it was quite a long. And here you can see the figure A and B. This is the that was the petrified eelfish. Still, the Unit 3, Department of Surgery, Sir Solomon Medical College has this tube with this electric fish as a record souvenir, or you can say. And at figure C, you can see this is the perforating site in the rectosigmoid junction, and you can see this is quite necrosed and contaminated area already. In the next course of event, the surgeon went to go for the heart metal procedure. And in the figure D, you can see that these are the clusters, multiple fish bones that were clustered in the intraperitoneally in the abdominal cavity. So this actually gave us the explanation about these bizarre atypical radioapic shadows in the X-ray whole abdomen. So that gave us the explanation that what it was. So after the findings of surgery, we did find this. We did have this explanation. So I will shortly describe the Hartmann-like procedure. So think of it like here in the sigmoid colon, there is an infected or any pathological or any perforated site here, which can be contaminated. So in the next course of event, the surgeon will resect this portion of the gut and he will take it out from the abdomen. And after that, there is a two ends. One is the proximal end of the gut, and another is the distal end of the gut. So the proximal end of the gut is creates a new outlet in external to the abdomen, which known as colostomy or sigmoidostomy, and the distal end of the gut is clamped and it is non-functioning for the rest of the course. And after appropriate environment of the abdomen and viable what can I say? It after the proper the health monitoring. After that, we can again make the functioning gut tube with a definitive surgery. So at that time, when the perforated site was contaminated, it was not physiologically sound choice to anastomose the gut and leave it in the abdominal cavity. So the best choice and best physiologically sound choice was this heart like procedure. So after all this, our confirmatory diagnosis was traumatic colorectal perforation, specifically rectosigmoid perforation due to rectal insertion with generalized peritonitis and severe septic shock. So next come the outcome after doing the emergency laparotomy and Hartmann-like diversion. The patient was transferred to ICU with vigorous inotropes and broad spectrum antibiotics. There was enough support, vigorous support from the ICU team as well. But without with also with despite this full supportive care, the patient was still persistently deteriorating, and unfortunately, after on the third post-operative day, the patient was expired from septic shock. And autopsy was reviewed by the patient's relative. So till this day, we didn't know the mechanism of injury. It still remained unclear to us attending physicians. So after that, we have the literature review. As I've said earlier, only 3 previous cases of ill-induced colorectal perforation that report worldwide. And surprisingly, all cases are middle-aged males and all are from Asia. And the perforating site mostly from rectum or sigmoid colon, and all previous cases presented early. That was the main focus point. My main focus point here, that all previous cases presented early and survived with sigmoidostomy or colostomy. But unfortunately for our case, particularly this case, though this was he was the youngest patient among all 3 of them, but there was a major 4 days delay, which ultimately causes the only reported fatal outcome in these reported cases. And this literature review box was published in the article as well. Here you can see the first 3 cases. One also another one also is from Bangladesh. All 3 was in their 50s. All 3 are male. Other 2 was China and Hong Kong. The perforating size was almost sigmoid colon rectum, and the main thing is duration of even 2 hot missile admission was 5 or 2 hours, and it also came as early as possible. Roof of entry, all of them was anus. Intervention was almost same as well, exploratory laparotomy and sigmoid colonostomy. And outcome was the previous 3, all of them are survived. But unfortunately for our case, there was a 4 days delays to seek the medical care from the patient party, from the patient. So the patient ultimately unfortunately expired on third post-operative day. So what will be the discussion about this particular case? So live ill movement actually causes the dynamic tissue trauma, which ultimately leads to progressive tearing through the gut wall and migration of that ill fish into intraperitoneally in the abdominal cavity. And as we did our DRE and proctoscopy as well in case of our patient, but we didn't find any peculiar results. So normal DRE or pectoscopy does not exclude proximal or higher up foreign body migration. Atypical radio-opaque shadow may mislead initial interpretation of the diagnosis, and here is the main point, that is the major delay of the patient to come to us, which causes diffuse peritonitis, sloughing of the gut wall, and ultimately leads to severe septic shock, which then leads to poor prognosis of that patient. Hartmann-like procedure, as I have discussed, chosen due to the non-viable rectosigmoid tissue and gross contamination of the perforated site. And diagnosis is often delayed due to embarrassment, which we, the attending physician, was thought about at that time, that this embarrassment actually caused that patient's life. The whatever it is, he didn't disclose this information to their relatives, or the patient relatives didn't disclose to us. So these embarrassment is, the diagnosis delays due to the embarrassment, unreliable history, or unconscious patients. So the lesson we learned, we should consider unusual etiologies when history is unclear or concealed. We have to prepare ourselves through all possibilities. Normal rectal examination DRE does not exclude higher up foreign body migration. Atypical radiological shadows warrant broader differentials. Delayed perforations leads to extensive contamination and high mortality. In massive sepsis with non-viable bowel, Hartmann-like procedure diversion remains the safest choice still. And last but not least, as a physician, we doctors should always maintain non-judgmental history taking, as it will invite the patients to cooperate with us, to give us that slight information that will help big in our diagnosis and in the course of treatment. And lastly, another thing at the end of this presentation, I want to introduce to you guys the SCARE guideline, not to per se scare you guys. So, case report often miss key clinical, ethical, and or diagnostic details. So, the surgical case report, or in short, SCARE guideline, provides an internationally accepted structure to gap these gaps you have in your case report writing. So it helps clarity, transparency, and reproducibility of your case report, and followed by most scientific journal, surgical journal worldwide, different publications, including the one which this case report was published, where this case is published. So it is also acknowledged by the SCARE guideline. As you can see in this screenshot I have taken from the publications, here the author also did mention that this case report is written according to the SCARE 2025 guideline. So it will create a strong ground. If you ever think about writing any case report, it will create a strong ground for your case report to be acknowledged worldwide, scientific journal or article. So what actually SCARE actually covers? So it organizes the case report into essential component that you need to include in your case report: structured abstract, patient information, and definitive timeline from the diagnosis to outcome of the surgery, diagnosis, reasoning, intervention, details, outcome, and follow-up, ethical documentation, very much important, the consent of the patient or patient party, and lastly, clinical discussions with literature reviewer context. So ultimately, it ensures the report to tells a full clinical picture, your story from the patient presentation. The patient came to your door in your medical care, up to the decision making in the diagnosis, then the surgical operation, surgical intervention, ultimately the outcome of the patient. What was the outcome of the surgery? So all of this in a standard publishable form. So why we should learn, why I'm talking about this in front of you, why we should learn this SCARE guidelines? So simplifies the case report writing, especially for beginners like myself as well. I am starting to think about writing a surgical case report. So I think it is a great helping tool, a great starting point for my case report writing journey. And it reduces the chance of rejection by the journals. As I have said earlier, it is recognized worldwide by the most sophisticated journal publications, and it makes our report more credible, complete, educational. And 2000, the latest update 2025 update includes AI use transparency, which is very much important, because as we know, in our time of era, we do use AI a lot, and it is a quite an helping hand. But some of the journal publications does not approve the use of AI. But this 2025 guideline includes that if you use the AI you can declare it in your case report, then it will be okay. So thus it creates the AI use transparency, which ultimately strengthens your academic integrity, which is a very valuable yeah, checklist to integrate in this latest update. And lastly, it is a great starting point for anyone trying to build a publication early in their career. So this is the SCARE guideline 2025. I have just shown a glimpse, a screenshot of the first page. Here you can see the checklist. There was, I have shown you 1, 2, 3, 4, 5 checklist. There was about 16 to 17 checklist as per se. I am, if I'm wrong, not wrong. So the thing about this, it's like this. For example, you are writing a case report in your left hand, and you are more or less completed all of the case reports. So on the right hand, you have this guide list, you have this checklist. So you are checking the checklist that you have. Give the title, you give check. You have completed the abstract, you give check. You have completed the investigation, surgical intervention, you have give the check. So whatever the items that were gaps in your checklist, you have to include that in your case report. So it helps you to have a concise guideline through your case report, so that you don't missed any of the important topics. So that's why I think it is very much helpful if you are thinking of yourself to writing any surgical case report. And also, as well as a medicine report, there is also a guideline that is known as care guideline, and the care guideline is slightly modified for the surgical intervention. So that was all about from my end. And again, I like to thank you, the Dream USMLE organization, for giving me this great opportunity. And I hope you like my presentation. Thank you very much.
Thank you, Dr. Zubair, for giving us an outstanding presentation for a rare case, which is found in, which is reported three cases before, and I really enjoyed the presentation. And at the end, you just reported the SCARE guidelines, which will be great help for the beginners who are planning to start writing case report. So thank you very much, Dr. Zubair, for the nice
You're welcome.
presentation. Okay. So now I will come to the Dr. Zakir. So Dr. Zakir will give us presentation about a journal articles. It is about severe burn injury from the common Asian practice of heat application in patients with diabetic neuropathy. So I'll give floor to the Dr. Zakir. So please have a floor, Dr. Zakir.
Hello everyone. Can you see my screen?
Yes, we can see your skin screen.
That's great. Um, uh, the title of my case report is Severe Burn Injury from the Common Asian Practice of Heat Application in Patient with Diabetic Neuropathy. Why I choose that article? Look, it is winter season and we're from South Asian country. We all have family members in older age, and some of them are having diabetic neuropathy usually. So most of the people of our country, that adult people that more than 50 or 60, maximum people having joint pain of different joints like hand, foot, like for rheumatoid arthritis or gout, something else. So they commonly apply heat on their different joint from a relief of those pain. But when they are having diabetic neuropathy, sometimes they can't understand about the burning pain, and though they got that those heat application induced burn. So and today I'm going to introduce this article that is presented in a journal, international owned journal. It's a paper from Taiwan, and they studied almost 16 diabetic neuropathy patient. They are having those problem. So first of all, we should understanding the risk, how we getting the problem of burn induced by diabetic neuropathy. In underdeveloped country like in South Asia, like Bangladesh, India, Pakistan, or so on, they have a traditional practice of application of heat in the winter season due to partial relief of pain or sometimes partial relief from cold. So this practice is very much common in our society, and I choose this article for presentation because this is I think this should be helpful for everyone who are watching this presentation and for their family members or their study or handling their patient in their hospitals. So I choose that, and it is very much traditional practice in our society. So, diabetic neuropathy having with this problem, they can't understand about their pain sensation. And as they are having diabetics, when they are burnt, the skin is injured, and they are having infection, this wound healing is delayed. This wound healing is delayed due to diabetics. And we all know that most of the patients of our country are incompatible with their medication for diabetes, as it is a long time we should take the medication. So the diabetic neuropathy induced burn is it's maybe a very much burning issue to our country. So I choose that, and we have a study design from the article. The study was held in Taiwan, and they are studied about 16 diabetic neuropathy patients who are having heat-related burn. In they studied those patients from 2015 to 2021, and a tri-service general hospital in Taiwan. It was a retrospective observational study. And first of all, we are having the demographic and data and comorbidities. As most of the patient have a look at that mean age of this population, of the 16 people, or mean age was 65 years old, almost 65 years old. Or as they are aged people, most of them had other comorbidities like hypertension, chronic kidney disease, peripheral arterial disease, coronary arterial disease. So having this problem with diabetic neuropathy, when they burn their skin, they become very complicated. Sometimes they need surgical intervention also. Mechanism of burn was, most of the burn was contact burn, like heater and pads, then a hot water bag, and so on. The most of the burn were contact burn, then some of the scalp burn and radiation burn. And most of the patient was observed that they are affected in their feet, about 94% of our patient, because we can we can say that most of the patient with rheumatoid arthritis and other joint related pain, most of them affected in our foot, and our diabetic neuropathy start from the foot first. So most of the patient having the injury first at the foot. And there is a alarming data that in a previous page, that about 50% patient have third degree burn. So we can understand from that most of the patient have third degree burn, but they can't understand they are burning their skin or tissue. So we should be more careful about our family members though are having diabetics. Though the burn of our in this case is almost very few, almost 1.5% it of our total body surface area, but the burn is second degree or third degree burn. So that may be causes life-threatening condition in some cases. Have a look at that. About 14 patients of all those 16 patients have required surgical intervention. So most of the patient having a burn, they needed surgical intervention. But think about our country, most of the people living periphery area from our hospital, and they cannot afford to treat themselves from a renowned hospital. So maximum patient in our country, I think, cannot go to hospital before they are infected. So maximum of the patient when they are having diabetic neuropathy with burn, they can go to hospital before they are infected, and they should amputate their feet or hand or their fingers from hand or foot. We can see that with different time that most of the diabetic patient having amputation, they are many of the cause due to diabetic ulcer, and some of the diabetic ulcer due to burn. Some of the patient they need to skin graft also. Here we can see 63% of those all the patient having skin graft. And here we can see the outcome. 44% of the patient having infection. As I said before, that they can't understand their severity, they are not well educated for this cause. After burn, they are going to hospital in delay. So almost 44% of the patient having infection in their burn. 19% of the patient need to amputation their foot, finger also. And there is a important data that 6% patient also needed ICU admission. So we can see, and the other comorbidity of those patient making those condition is more complicated. So what can we discuss in a short about those paper? We should applicate the heat from a safe source or others, or say safe source, and we should first save themselves those dangerous cultural practice. And the delayed detection can from diabetic neuropathy. Here we can say that diabetic neuropathy is in our society. We can diagnose diabetic neuropathy in a delayed phase, as like with some of the patient having diabetic retinopathy, but they are think about that they are cataract. But sometime they are having their issues with their sensation feet and hand, but they can't understand they are having diabetic neuropathy due to uncontrolled diabetic mellitus. So delayed detection is one of the vital cause of this diabetic neuropathy induced burn in our patient. And other comorbidities, they also help to burn and the infection in the later phase. So what can we do with them? How can we prevent those surgical or others complication from other complication and avoid those condition? We should get awareness we should arise awareness to our people that we should avoid prolonged heat exposure, especially during sleep. Avoid infrared halogen lamp. Some of our patients, some of our family members having a room heater. They are putting their room heater in their pain related for joint and foot, hand, and so on. So sometimes they can't understand about their burn of their skin or other part of their body or tissue. Some food but safe food but temperature, and we should ensure that the food but temperature of our water should below 38%. Temperature check should be vital for the water. And patient education is very much important in this case, because education and awareness is the key to prevent or eradicate most of our case. So patient education is very much important. And at last, we what can we do if we got burned with our skin or other tissue? We should first immediate first aid management should be applied, like cool water running for 20 minutes, and other first aid antiseptic cream, or some others intervention that we can minimize the infection rate. And we should go to hospital if we have a major burn, and we can get help from our doctors. So I tried to simplify my article to you all. So I tried to present my article so it can be helpful to you and your family members and your patient. So thank you everyone for being patient.
Thank you, Dr. Zakir. Um, it was a very nice presentation, and I really enjoyed the way you have arranged the PDF, and I really love the this way you have presented. And yeah, that's a great way to start, I would say. So, do we have any questions? Let me check at first. Most probably, we don't have any questions in online Facebook Live. But if anyone has any question, you can ask in the Facebook, comment in the Facebook Live, live in the Dream Assembly group, and from the other observers. So, do any of you have any questions regarding today's journals? Or you can ask any questions how to present our journal. You can ask those also. Anyone has anyone
There is
has
an
any questions?
important question that uh,
Okay, so let me ask you some questions. So I've seen the Dr. Zaki that you have presented a case that is from Taiwan, and about the beginners who are planning to give a presentation in the futures in the journal club. So what will you give advice to the future presenters? বাংলায়
thank you
বলতে পারি,
অনিক
আচ্ছা
ভাই।
বাংলায় বলি আমরা,
ওকে,
সমস্যা নেই।
ওকে। বেসিক্যালি এটা আমার ফার্স্ট প্রেজেন্টেশন, সো ল্যাঙ্গুয়েজ রিলেটেড কিছু কমপ্লিকেশন হয়েছে আমার ক্ষেত্রে। আর আরেকটা ব্যাপার হচ্ছে, ওই যে বারবার মাসুদ ভাই যেটা বলছিলেন যে বারবার হচ্ছে বলার প্র্যাকটিস করা, এটা খুবই ইম্পর্টেন্ট। আর আরেকটা
হুম।
জিনিস হচ্ছে, আপনারা দেখছেন এখানে আমার ইয়েটাতে, পিডিএফটাতে, এখানে কিছু ভালো ভালো ছবি, আমার ছবিগুলো যদিও আমার খুব একটা পছন্দ হয়নি, কিন্তু এই ছবিগুলো পছন্দ না হওয়ার কারণ হচ্ছে এগুলো হচ্ছে এআই জেনারেটেড ফটো। আমি গামা অ্যাপটা ইউজ করেছি এই ইয়েটা বানানোর জন্য, স্লাইডটা বানানোর জন্য। তো আমি প্রথমে কিছু ছবি নেওয়ার চেষ্টা করছিলাম, মানে অ্যাকচুয়াল কিছু ফটো, বাট ওইখানে কিছু কপিরাইট ইস্যু ছিল। সো কপিরাইট ইস্যু ছিল, এবং এই যে পোড়া বা কাটা রক্ত বা এই ধরনের ছবি নিতে গেলে বা আপলোড করতে গেলে কিছু সমস্যা হচ্ছিল। তো পরবর্তীতে আমি ভাবলাম যে ঠিক আছে, এগুলা বাদ দেই, কিছু সিম্পলিফাই করে কিছু ছবি আমি এখানে ইউজ করেছি। তো আমি যতটুকু আমার এক্সপিরিয়েন্স হয়েছে এটা তৈরি করতে গিয়ে বা হচ্ছে প্রথমে আর্টিকেল সিলেক্ট করতে গিয়ে বলি। আর্টিকেল সিলেক্ট করার ক্ষেত্রে আমি চেষ্টা করেছি যে আমাদের হেল্পফুল হয় হওয়ার জন্য এই মুহূর্তে, এবং যেটা খুবই কমন একটা ব্যাপার থাকবে, এবং সেটা থেকে সবাই একটু করে দেখতে পারবে বা নিজের ক্ষেত্রে বা নিজের যে পেশেন্টের ক্ষেত্রে এটা একটু, যাতে একটু অ্যাওয়ারনেসটা গ্রো করা যায় অ্যাটলিস্ট, যে হ্যাঁ এটা হচ্ছে কিছু কিছু ক্ষেত্রে। যেমন আমাদের আমার নিজের ফ্যামিলিতে হচ্ছে ডায়াবেটিক পেশেন্ট আছে, তো নিউরোপ্যাথি হয়ে গেলে সেক্ষেত্রে কি সমস্যা হতে পারে এবং সেখান থেকে কি ধরনের সাবধানতা অবলম্বন করা যেতে পারে, সেই জন্য আমি আসলে এই আর্টিকেলটা সিলেক্ট করেছি ফার্স্টে। এরপর হচ্ছে আপনার এই প্রেজেন্টেশন, যে হচ্ছে এই স্লাইডটা বানাতে গিয়ে আমি গামা অ্যাপের হেল্প নিয়েছি। ওরা খুব সুন্দর স্লাইড বানায় দেয়, আপনারা যেখানে এই যে এরকম দেখতেছেন। তো এরপরে নিজের মতো করে কিছু এডিট করেছি আমি। তো আপনারা প্রেজেন্ট করতে চাইলে এটা ব্যবহার করতে পারেন। আর হচ্ছে আহ, মাসুদ স্যার আছেন আমাদের সবার মাথার উপরে, উনি খুবই হেল্পফুল আসলে। এবং আপনারা যারা প্রেজেন্ট করতে চান ওনার সাথে আপনারা নিজেরা প্রিপারেশন নিয়ে বা নিজেরা একটু ঘাটাঘাটি করে ওনার সাথে যোগাযোগ করলে আপনারা হয়তো বা সহজে প্রেজেন্ট করতে পারবেন। অনি ভাই আছে এখানে, অনিও বেশ হেল্পফুল মনে হলো, যদি আজকে ফার্স্ট ওনার সাথে আমাদের এখানে ইন্টারাকশন হয়েছে, বাট আই আই ফাউন্ড হিম ভেরি মাচ কোঅপারেটিভ। সো এই থ্যাংক ইউ পেশেন্টসের জন্য সবাইকে, থ্যাংক ইউ।
ওকে, থ্যাংক ইউ ডক্টর জাকির। ডক্টর জুবাইর, আপনার কাছে একটা প্রশ্ন, যেটা আপনার যে কেসটা আছে এটা আই মিন ওয়ান অফ দ্য রেয়ার কেস আর কি। যে কেসটা ছিল, এই কেসটা আসলে যে আর্টিকেলে দেওয়া হতো সেটাই আর কি পাবলিশ হয়ে যেত। তো যে কোনো একজন নিউ বিগিনার যদি আসে, তো সে কিভাবে সার্চ করবে যে একটা রেয়ার কেস, এইটা সম্পর্কে যদি কিছু বলতেন ডক্টর জুবাইর।
আহ, যদি আমরা হচ্ছে ঘাটাঘাটি করি কেস রিপোর্ট সম্পর্কে, স্পেশালি হচ্ছে এনসিএইচ, এরপর হচ্ছে ইউকে, এরপর ইউএসএ যেসব জার্নালগুলো, রিনাউন যেসব জার্নালগুলো আছে, সো ওখানে ফার্স্ট অফ অল আপনি কিওয়ার্ডসে যদি রেয়ার কেস রিপোর্ট, জাস্ট রেয়ার কিওয়ার্ডটা লিখেই সার্চ দেন, তাহলে হচ্ছে অনেক এই রিলেটেড, আপনার শুধু সার্জারি কেন, গাইনি, অপস, পেডিয়াট্রিক্স, মেডিসিন, সব ধরনের রেয়ার কেসগুলোই আসে। আর পরবর্তীতে যে জিনিসগুলো একটু আমরা ডিপে গেলে চিন্তা করি, নর্মালি হচ্ছে কনজিনিটাল অ্যানামালিস গুলো, এগুলো নিয়ে সাধারণত রেয়ার কনজিনিটাল, আমরা যে সময় একটা অ্যানাটমি পড়ি, অ্যানাটমি পড়ার সাথে সাথে এমব্রায়োলজিটাও যে সময় পড়ার চেষ্টা করি, তো বিভিন্ন রেয়ার কেসের এমব্রায়োলজিক্যাল বিভিন্ন কনজিনিটাল, আমাদের ইউএসএমএল স্টেপ 1 পড়ার সময় আমরা এই জিনিসগুলো ফেস করি। রেয়ার রেয়ার কিছু হচ্ছে কেস, মানে হচ্ছে এমব্রায়োলজিক্যাল ডায়াগনস্টিক প্যাথোলজিক্যাল কন্ডিশন। সো সেগুলো নিয়েও হচ্ছে আমরা যদি একটু সার্চ করতে পারি, ফর এক্সাম্পল হচ্ছে কনজেনিটাল ডায়াফ্র্যাগমেটিক হার্নিয়া, অ্যানিউলার প্যানক্রিয়াস, প্যানক্রিয়াসিক ডিভিসাম। সো এই ধরনের কিছু রেয়ার কেস, কনজেনিটাল কেস নিয়ে হচ্ছে আমরা সার্চ করতে গেলে আবার করতে পারি। আর অ্যাজ আপ সে যেটা বললাম যে হচ্ছে রেয়ার কিওয়ার্ডটা দিয়েই যদি আমরা করতে পারি, তাহলে আমরা ওয়াইড রেঞ্জে, ভ্যারিড রেঞ্জে হচ্ছে আমরা এই ধরনের কেস রিপোর্ট করতে পারি। স্পেসিফিক্যালি আমার এই কেসটার কথা যদি বলি, আমি সাধারণত একটু কম সময় পেয়েছি আর কি। যে সময় জার্নাল ক্লাবের কথা শুনলাম, এরপর হচ্ছে আমি আমাদের গ্রুপটাও জয়েন করতে একটু দেরি হয়ে গিয়েছিল। তো আমি আমার সিনিয়র আপুর কাছে জিজ্ঞেস করেছিলাম যে কিরকম কি, তো এক সপ্তাহের মতো সময়ের মধ্যে। সো আমি আর হচ্ছে বেশি একটা ঘাটাঘাটি করার সময় পাইনি, আমার এই কেসটা পরিচিত ছিল যেহেতু আমি ওইখানকার তৎকালীন অ্যাটেন্ডিং ফিজিশিয়ান, ইন্টার্ন ডক্টর ছিলাম। সো আমার কেসটা সম্পর্কে জানা হয়ে গেছিল, তো যখনই আমি ওটা লক অন করে ফেলি, তারপর থেকে হচ্ছে আমি আমার প্রেজেন্টেশনটা তৈরি করে এটা নিয়ে প্রিপারেশন করতে ফেলি। সো ওই ধরনের সার্চগুলো আমার করা হয়নি, আমার ক্ষেত্রে হচ্ছে এই কেসটাই আমার জানা ছিল, এটাই হচ্ছে আমার ফেমিলিয়ার ছিলাম আমি কেসটার উপর, এজন্য আমি এটা সম্পর্কে একটু ডিটেলস বলার চেষ্টা করেছি আপনাদের কাছে।
হুম। আপনি একটা স্কেয়ার গাইডলাইন সম্পর্কে একটা বললেন যে ফাইনালি আই থিংক এটা খুবই হেল্পফুল ছিল। আপনি যদি
জি।
আরো যদি কিছু বিস্তারিত যদি বলতেন, স্ক্রিন শেয়ার করেই বলতে পারেন, বাংলায় বলতে পারেন, কারণ এটা
ওকে, ওকে,
খুবই
আমি
ইম্পর্টেন্ট যেহেতু আর কি।
ওকে আমি হচ্ছে এই যে আমি তো এখানে জাস্ট একটা পেজ দিয়েছি। আরো হচ্ছে আপনার ইজিলি এটা হচ্ছে আপনার অনলাইনে সার্চ দিলে স্কেয়ার গাইডলাইন সম্পর্কে পাবেন, যে যে সার্জিক্যাল কেস রিপোর্ট। ঠিক মেডিসিনেও এরকম একটা আছে যেটা হচ্ছে কেয়ার কেয়ার
কেয়ার গাইডলাইন।
গাইডলাইন। হ্যাঁ, তো কেয়ারটাই মডিফাইড করে এসটা সার্জারি আগে বসানো হয়েছে, কজ মেডিসিনের থেকে আমাদের এখানে সার্জিক্যাল ইন্টারভেনশনটা তো আবার এক্সট্রা আসছে আর কি আমাদের কেস রিপোর্টে। সো দ্যাটস ওয়াই কেস কেয়ারটা করছে। তো এখানে যে জিনিসটা এরকম 1 থেকে 4, এই একে যেমন টাইটেল, দুয়ে যেমন কিওয়ার্ডস, তিনে যেমন হাইলাইট, চারে যেমন অ্যাবস্ট্রাক্ট, এরকম ওদের যে চেক লিস্টটা আছে অনলাইনে ইজিলি আপনি এটা খুঁজে পাবেন। 1 থেকে এরকম 16, 17, 18টার মতো এরকম পয়েন্ট আছে। প্রত্যেকটা পয়েন্টই হচ্ছে আপনার এরকম নির্দিষ্টিফাই করে পয়েন্ট করে দেওয়া, যে এই পয়েন্টগুলোতে 1, 2 লাইন 3 লাইন করে লিখতে হবে এবং কি কি লিখতে হবে একেবারে ডেফিনিটিভ করে হচ্ছে চেক লিস্টে লিখে দেওয়া আছে। সো আপনি যদি জাস্ট ওই গাইডলাইন ফলো করেন, আপনার কাছে পার্সে একটা ইন্টারেস্টিং কেস আছে, আপনার বড় ভাই, আপনার ছোট ভাই, আপনার সিনিয়র স্যার, আপনার আশেপাশে যে কোনো কাছে একটা সার্জিক্যাল কেস হোক, মেডিসিনাল কেস হোক, একটা ইন্টারেস্টিং একটা কেস আছে যেটা নিয়ে মনে হচ্ছে আপনার এটা নিয়ে কাজ করা যায়। তো ওই কেস রিলেটেড যখন আপনি একটু ইনফরমেশনগুলো গুছিয়ে আপনার কাছে নিয়ে আসবেন, এরপর হচ্ছে এই চেক লিস্ট দেখে ধরে ধরে হচ্ছে আপনার ওই জিনিস ধরে আগাতে হবে, যে আমি কি ধরনের টাইটেল রেডি করতে পারি, বা কিভাবে অ্যাবস্ট্রাক্ট তৈরি করতে পারি, বা কি কি আমার পেশেন্ট প্রেজেন্টেশনে ইনফোতে কি কি লাগবে, ইনভেস্টিগেশনে কি কি লাগবে, এরপর ফিজিক্যাল এক্সামিনেশন আমার কি কি জিনিসগুলো ইনক্লুড করতে হবে। সো এইভাবে ধরে 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 আপনি যদি 15 থেকে 16টা পয়েন্টই আপনি যদি টিক চিহ্ন দিয়ে দিতে পারেন, দ্যাট মিনস ইউ হ্যাভ এ স্ট্যান্ডার্ড এবং পাবলিশেবল একটা আর্টিকেল। সো এই দিক থেকে আমি মনে করছি, আমি নিজেও এই বিষয়টা সম্পর্কে জানতাম না, আমি আর্টিকেলটা আমার একটা ক্লোজ ফ্রেন্ডই পাবলিশ করছিল, ওই মেনলি কাজবাজ করছিল সব। সো আমি যে সময় কেস রিপোর্ট আপনাদের প্রেজেন্ট করার জন্য এই যে পড়াশোনা করতেছিলাম আর কি, এই পড়াশোনার সময় হচ্ছে এই এসকেআর গাইডলাইনের সাথে আমার পরিচিত, এবং আমি নিজেও খুব অ্যামেজড হয়েছি জিনিসটা, এবং আমিও খুব ইন্সপায়ার্ড হয়েছি। আমি বর্তমানে যে ইনস্টিটিউশনে আছি সেখানেও আমার ফ্যাকাল্টিদের আমি ইনভাইট করে হচ্ছে ওনাদের হেল্প নিয়ে আমি হচ্ছে এই গাইডলাইনের সাথে একটা ফিউচারে কেস রিপোর্ট পাবলিশ করার ইচ্ছা আছে আর কি আমার, এইরকম বিষয়টা।
থ্যাংক ইউ ডক্টর জুবাইর, এটা খুবই একটা নাইস উত্তর দিলেন আপনি আর কি। তো হ্যাঁ, আর যেটা বললেন যে মেডিসিনের জন্য যে গাইডলাইনটা আছে সেটা হলো কেয়ার গাইডলাইন।
হ্যাঁ,
আর যারা সার্জিক্যাল কেস রিপোর্ট লিখবে তাদের জন্য যেটা গাইডলাইন, স্কেয়ার গাইডলাইন। সো আই হোপ যারা কেস রিপোর্ট লিখতে যাবেন তারা শুরুতে লাইক এই গাইডলাইনগুলো চেক করবেন যে কোথায় কি করতে হবে। আর আমি বলবো দুজনেই প্রেজেন্টেশন খুব সুন্দর ছিল। ডক্টর জাকিরের লাইক কি বল পিডিএফটা, আই মিন দ্যাট ওয়াজ ফ্যাবুলাস আই উড সে। And Dr. Zubair presentation, it was a great, outstanding. And thank you very much, everyone. I hope we don't have any more questions. So I believe we can conclude the session for today, and hope for you all. And have a great day.